Welcome to AETCM, the Emergency Medicine Channel. One 31-year-old male patient came to ER with complaints of fever since 4 days associated with multiple episodes of vomiting and loose stools. On initial 10-second assessment, patient was conscious and oriented. On primary survey, coming to airway, appears patent, there is no pooling of secretions. Breathing part, ironary bilateral equal with respiratory 20 breath per minute and saturation maintaining on room air 99%. On circulation part, BP was 120/80 with the pulse rate was 107 beats per minute. Disability, GCS was E4, V5, M6, pupils bilateral equally reactive to light. Exposure what? Temperature was 103 and GRBS was 120. In view of temperature 103, we given PCM 1 gram IV starts. Adjoint to primary survey, VBG was coming to normal and ECG showing signs tachycardia. On point of care, showing total count is 6.3, CRP was 51 and platelet was 217. On initial assessment and history wise, we sent the routine blood investigations, CBC, RFT, LFT, blood cultures and loose stools also, so sent stool routine and stool culture also. Coming to ample history, 31-year-old male patient came to with no comorbidities, there is no drug allergies, came to ER with complaints of fever since 4 days with high-grade fever associated with chills and rigor. Patient also complained of multiple episodes of loose stool and vomiting. Vomiters contain only food particles and loose stool, there is no blood in the stools. Patient is living outside Kerala, working in a jewelry, and he had a regular history of intake of food from street vendors. Patient had no history of altered sensorium, seizure, abnormal movements, and blood in stools. No, sorry. Coming to general examination, on examination, there is no pallor, ictus, clubbing, sinus lymphadenopathy. On system is also within normal limits, sir. Then after 2 days, the blood culture came to positive for Salmonella typhi. So with the history and clinical picture and outside food intake, with blood culture, we diagnosed as typhoid enteric fever, sir.
Okay. So tell me the clinical features of enteric fever, typhoid.
Fever, abdominal pain, vomiting.
What is the type of fever commonly seen in
step ladder?
What is step ladder?
Initially, patient will have fever rise, then stabilize again another episode.
Everyday rising of.
How many days? How many patients with step ladder you have seen?
Nowadays, peak we can see.
You cannot see. That is a problem nowadays because patient will be taking paracetamol every day. So only the most relevant history in typhoid nowadays is fever does not come down. Every day fever is increasing. You cannot document it as step ladder. To document that, you have to admit the patient. You have to stop paracetamol. Then you have to document. But we can see that patient will be highly feverish, and every day it will increase in spite of the normal antibiotic what we give in routine practice. The fever increases, whereas in viral fever 1 or 2 days fever will be there. Then the fever pattern subsides. Most of the types of fever subsides within 1 or 2 days. But typhoid is one condition. Every day you have high degree temperature. Then other than that, so temperature is like that. Other than that,
abdominal pain, loose stool, diarrhea.
Loose stools are common in which type of typhoid?
Paratyphi.
Paratyphy. Typhoid also you can get, but it is more common in paratyphy. Then
vomiting, abdominal pain.
Then
complication related to sepsis, multi-organ dysfunction.
Other clinical, because clinical findings in enteric fever is very classical. You can make a
Rot spots.
Cotted tongue is a very classical finding. Pulse rate.
Relative bradycardia.
What is relative bradycardia?
Dissociation between the pulse and temperature. Normally, if patient had 1 degree rise in temperature, there is 10 heart rate and 10 pulse per minute.
Okay.
Relative bradycardia means patient doesn't go into bradycardia, but with the degree of temperature rise,
it will not be there. What is an exception for that relative bradycardia in typhoid? In typhoid, some patients can have tachycardia, peritoneal. There is secondary abdominal infection, then you get tachycardia. So you have to be very careful. If you are seeing a suspected typhoid and pulse rate is very high, then there is a possibility of early peritonitis. Okay, so these are the common clinical findings. Then abnormal multi-organ dysfunction findings. What are the other findings?
Raised the LFT.
LFT can be raised.
So we can confusion with the viral hepatitis also.
Okay.
Patient had history of abdominal pain, vomiting, diarrhea with raised LFT. RFT also leads to.
It is not. Malaria is one condition where renal failure is not very common, but later phase of typhoid you can get renal failure. So typhoid initial RFT elevation is not very common, whereas in leptospira and all it is very early. Okay, but it can elevate. Then encephalopathy is another important finding. So encephalopathy is a classical finding in typhoid. What is the type of encephalopathy?
Typhoid encephalopathy.
What is the typical feature of that? There is a name given for that. You may not see nowadays because we give early antibiotic, but in even some areas of India this can happen because patient has not taken antibiotic. They come with more of complications. What is muttering delirium? What is it? Muttering delirium. Patient picks up like bedsheet things like this. This is very rarely nowadays we see because we start antibiotic early itself. Okay, so that is one of the clinical findings. So these are the common findings. But whenever patient is having abdominal pain, you are supposed to take one immediate investigation.
X-ray rectal abdomen.
X-ray rectal abdomen. Okay. How do you? These are the clinical findings. How do you investigate suspected case of typhoid?
In first week, there is a blood culture will be.
Normally, we do any patient. We do CBC, CRP. What will be the finding in that?
Normally, typhoid fever will show leukopenia.
Leukopenia. All bacterial infection, you get elevated count. But this is one bacterial infection, you get a lower count. Then,
if there is leukocytosis, we will suspect patient
peritonitis. Again, leukocytosis is a feature of peritonitis. Then, platelets.
Platelets sometimes thrombocytopenia.
Mild thrombocytopenia is known in typhoid. Hemoglobin. You might have seen so many patients with fever here. What is a normal hemoglobin in them? What is the first finding?
Hemoconcentration.
Hemoconcentration is most of the patients you get dehydration, hemoconcentration. That is a common finding. Okay. Then CRP will be elevated. Procalcitonin
elevated.
So most of the time it is a local infection in the abdomen. So procalcitonin will be slightly elevated. When the patient goes to sepsis only, you get very high this one. Okay. Or lung involvement, you can get very high procalcitonin. Then LFT.
LFT is more than 500.
Okay. SGOT, SGPT will be in hundreds. Okay. Then creatinine.
Creatinine also sometimes it is elevated.
Normally creatinine is not elevated, but patient with severe fever, dehydration, pre-renal renal failure is very common in typhoid. Diarrhea. Okay. Then
we can send blood culture is.
Blood culture is a gold standard investigation in the first week.
More than 7 days, we can send viral test also.
Okay. Viral test. What is a normal viral test finding?
Normally, it is if there is not fourfold increase in the titer.
There are two titers, O titer and H titer.
O titer is for surface antigen, H titer for cellular antigen.
Okay, which is more specific for
specific for is O titer. Because it is early coming in.
3 to 4 fold elevation from the baseline or from 1 day to 1 or 2 days. That is very classical. Highly increasing titers are very classical. Or if you first itself very high titers also can be observed in some patients.
Then if 3 weeks we can send stool culture.
Stool culture can be positive. Then one more culture.
Bone marrow.
These are the common thing. Nowadays we don't do all these things. We get blood culture positive first itself, or we can go for viral test. Okay. And how do you manage the case?
Management is basically drug of choice is fluoroquinolones.
Drug of choice
there is
was
some resistance is there, so you can.
Lot of resistance is there nowadays. So it is not a drug of choice in at least in our country. It can be tried. There is no contraindication. It can be tried. Some of the patients are resistant to that.
So we can start with the third generation cephalosporin like ceftriaxone, cefotaxime drugs with 1 gram or 2 gram OD with 7 to 10 days. For fluoroquinolone use, if you inject Ciplox 500 mg BD for 7 to 10 days.
Okay.
Then we can use azithromycin. Then if there is any severe complication, multi-organ dysfunction, we can start with carbapenems.
Okay.
Carbapenems.
Okay. All depends on your culture report. Whether you go hike up the dose of hike up the antibiotic, that depends on the culture. The initial dose is initial antibiotic of choice is always ceftriaxone, cefotaxime, all these things. If after getting culture, if it is resistant to that, then you have to hike up to piperacillin tazobactam or meropenem, whatever it is. Okay. In enteric encephalopathy, what is the treatment?
Antibiotic along with, you start with steroid like dexamethasone. Dexamethasone has ability to cross the blood-brain barrier. So you can give 3 mg per kg loading dose.
It's a very high dose comparing with to other usual doses what we give. There is only difference.
3 mg per kg loading dose followed by 1 mg per kg every 6 hourly for 48 hours.
Okay.
Along with antibiotic we can.
Okay.
Then hydrate the patient. Symptomatic management like ORS, ringer lactate, fluids you can give.
What is chronic carrier state in type?
Chronic carrier state, patients with passage of typhoid organism in urine or stool more than 12 months. They are not infective because of their high levels of titer antibodies against the O antigen. So they are not symptomatic. This is the chronic state, and we can treat the carrier state by giving fluoroquinolones like Ziplox or.
Why fluoroquinolones are the choice in this condition?
Because they have intracellular action, and it also penetrate the gallbladder.
It secretes through the gallbladder, and it will concentrate in the gallbladder.
Bactericidal and intracellular action also. It can start with 500 mg BD for 4 weeks is the treatment for carrier to prevent the carrier state. And also we will send 24 hours, at least 24 hours, 3 stool culture samples come to negative, then we can stop the treatment.
Which type of patients are prone to spread infection in the community? What type of
working in the
those who are working in the kitchen, chef or something like that.
Typhoid maybe.
Okay, so that is we should be very careful. If that patient is having that type of job, then we have to definitely give. Anyway, we have to give, but definitely look for the chronic carrier state. Vaccines.
Vaccines, we can give polysaccharide vaccine, VI vaccine, but it was not good in paratyphoid because it has no action with the antigen. Then we can give, for that is 0.5 ml subcutaneous dose and repeat every 2 years, the booster dose we can give. Then we can give live vaccine or oral vaccines. Live and oral vaccine. Live and oral vaccines will elicit both serum, intestinal antibodies and cell-mediated immune response. 3 doses is there, protection for up to 5 years as live vaccines.
Okay, anything else you want to add? Want to add nothing? So yeah, you have covered almost everything.
The other thing is extensively drug-resistant typhoid will be there. That we define as those resistant to 5 antibiotics like ampicillin, trimethoprim, salmeterol, chloramphenicol, fluoroquinolones, and third-generation cephalosporin. In this type also you can start with for XDR typhoid carbapenems, drug of choice.
Chloramphenicol was used earlier. Now we are not using.
Side effects is there.
That used to produce a lot of side effects like bone marrow suppression, and drug resistance was very common. Now it was stopped for many years. Okay, can you tell what is drug holiday? Drug holiday.
While we giving 2 days holiday, well, like for the dioxin.
Okay, so we use it in so many conditions like for digoxin 5 days by 7, 2 days holiday is given. That is to prevent the tachyphylaxis. Nitrates 6 hours drug holidays, 8 hours drug holidays given. So many drugs we have tried. In antibiotic, what we have to think is there are some drugs, certain drugs like fosfomycin, chloramphenicol, that was not used for many decades. Okay. Now when we use that, many bacteria are susceptible to that, which was resistant to that. Now it is becoming susceptible. So that is also type of drug holiday. So in some hospital they use like meropenem for 1 year. next year they may not use it. They go for some other drug for 1 year, so that by that 1 year, most of the things will again, that susceptibility may come back. So that is also a type of drug holiday, but for that it is very difficult to practice in our country. But chloramphenicol, now it may come back for, like fosfomycin has come back for urinary tract infection. It may come back. Only thing is it can produce some side effects. What is the common side effect of chloramphenicol? It was used now previously. Bone marrow suppression. It is a drug which can produce severe bone marrow suppression.
And also one is and before starting fluoroquinolones in children, the side effect is cartilage toxicity and arthropathy. So
but previously it was told like that, but nowadays that side effect is not like documented in many newer guidelines. They say fluoroquinolones can be tried, but there are no clear-cut like standard guidelines. But some papers say that we can use it. I don't know exactly what is the current status. Okay, thank you.